Anxiety disorders. Anxiety disorders still face mis- and underdiagnosis. And this is also due to the difficulties in differential diagnosis among subtypes, but also due to the fact that there are so many co-occurring comorbidities with anxiety disorders and somatic also complaints. Nowadays, the standard methodologies are relying on self-reported surveys and of clinical interviews, which are great, but come with some limitations. And we have that we are not collecting data in real time, and this is causing the risk to have the recall bias. Recall bias is essentially the fact that we are not very capable of reminding well how we were feeling in the past. Moreover, there are some limitations in the healthcare system nowadays, lack of clinicians, and so the doctors, psychiatrists, psychologists have less and less time to spend with their patients. Moreover, the meetings are taking place mostly in controlled environments, clinics and hospitals, far away from the daily scenarios, which are the triggering events, which elicit the disorders in patients. And what we are trying to do, essentially, is to explore if and how technology can help in mitigating these limitations. Emotions are responses to outside events, and standard self-reported approaches essentially analyze them already, but they've been criticized to be paradoxical in evaluating the emotional responses of people. Moreover, clinical interviews may lack in specificity and also in cross-cultural validity. So what technology can add to this? Essentially, technology can open us to monitor emotions in different modalities, new modalities, which range from analyzing the bio response, the physiological responses of the body, which are essentially a mirror of the autonomous nervous system. And we can also collect longitudinal self-reported data, such as surveys, diaries, audio and video recordings. Previous studies show that multimodal approaches outperform unimodal ones. So what we are proposing is to implement commonly available, commercially available devices, such as wearables and smartphones, which are free from the stigma which is usually linked to medical devices, and are also available, easily available to the public, and to implement them in the clinical practice. These devices allow us to collect biosignal, both passive, such as PPG for heart rate, just hour for galvanic signal response, but also active, such as one-lead ECG, and of course also longitudinal self-reported data. The problem is that study also say that in 3 months, there is a 50% rate of dropout for digital solutions in mental health. So to address this historical challenge, we are embracing a co-design approach, which involves users, which involves patients and clinicians, since the beginning of the design process of the solution. This will range from analyzing the problems and the needs till the evaluation of the solutions once active. So which kind of self-reported modalities should we include? How should we display this data? How should we share the data with clinicians and other stakeholders? When the solution should interact with the user, send notifications, and whatever. All these aspects will be covered in this process of co-design. Yes, if you are interested in collaborating with us in co-designing solution, see you at lunch. Thank you so much.
Thank you.